We'll start now. Hello, everyone. Good evening for all of you. You are welcome in the second pre-revision for the KAPS exam. We are preparing for the coming March 2024 exam. Okay. In the last revision or pre-revision, we discussed some of the questions from the previous exams. Today, also, we'll discuss again more questions and see the rationale and see the most important topic related or the concept related to each question that we will discuss. Today we will have about 25 questions. So please pay your attention with me. And if you have any question at any time, please ask about it. Let's start. The first question today, treatment of Trichomonas vaginalis. Is it metronidazole, amoxicillin, doxycycline, or miconazole? Actually, to choose the right answer here, we should take care about something. Firstly, this organism is anaerobic one. So, to choose the right one, we choose which of those antibiotics used to treat anaerobic organisms. Okay, you'll find that metronidazole is the right answer here. Okay, metronidazole is the right answer. Let's see the next one. Drugs that have different crystal structures. So they are different in the change in different structure or the shape of the structure, either triagonal or tetragonal or different shapes of the crystals. What we call this? The same compound, but with different structure or shape of the crystal. It is called
Polymorphism.
Yes, it is polymorphism. Okay. Let us see the next one. All the following are acceptable uses of magnesium hydroxide except magnesium salts. The different salts of magnesium have different uses. The most common use of those salts, like magnesium sulfate, magnesium hydroxide, magnesium citrate, they are osmotic laxatives to treat constipation. Okay. Also, as antacids to neutralize the acid of the HCl. So they can treat heartburn, they can treat dyspepsia, they can treat constipation. But hemorrhoids, there is no direct treatment here. The use of them in hemorrhoids to avoid the strain. So they are decreasing the constipation so that the patient who having hemorrhoids have no problem with the constipation, but not directly treat the hemorrhoid itself. Let us see the next one. Which of the following have no active metabolite?
Nifedipine.
Nifedipine. If we study all the choices, let us see the choices. Here we have codeine. Codeine will convert it into what?
Morphine.
Morphine. Yes. Through which cytochrome?
Cytochrome P2D6.
Yes, 2D6. Imipramine having a metabolite. What is the metabolite of it?
Desipramine.
Desipramine. Okay. Also, clopidogrel have another metabolite. Clopidogrel itself is a pro-drug. Sorry. Clopidogrel is a pro-drug. So it should convert it into its active form, active metabolite. Through which cytochrome?
2C19.
2C19. Yes, that's good. Therefore, the remaining one that which have no metabolite or no active metabolite, it is nifedipine. Okay. The next one, which is safe in pregnancy.
Sorry, doctor. Sorry, please.
Acyclovir.
Which isomer is effect is R or S for clopidogrel?
S is the effective one.
S.
Yes, yes.
But warfarin is 2, yeah, is R and S.
For warfarin,
Both of them.
both isomers are active. We are talking about the therapeutic activity, okay, not optical activity. They care about the difference between both. Okay, so when we are talking about the therapeutic activity or pharmacological activity, for warfarin, both are active. So either S isomer or R isomers, both are therapeutically active. While clopidogrel, S is the active form or the active isomer. I mean also therapeutically active isomer for clopidogrel.
Thank you.
The next question. Which is safe in pregnancy? Acyclovir, lisinopril, sulfonamides, warfarin. Also, the choices are easy to choose. Why? If we exclude the choices, lisinopril, one of the ACE inhibitor, which is category X in pregnancy, so excluded. Warfarin also is category X, so excluded. Sulfonamides also would be included because it's not safe in pregnancy. The remaining one here will be acyclovir. So acyclovir is the safe one regarding to the choices in pregnancy. Okay. Take care for some recalls when you study them. Some recalls giving you the answer. Okay. And some questions, there is no absolute result. It's just comparable to the other choices. So when you study, there is no only one choice is the right. The choice here, according to the different choices present in the exam, the 4 choices, the best one. Okay. So sometimes when we compare acyclovir with another drug, it's less safer. Did you get my point? Let us see this one also. Esomeprazole will cause what? Increase in absorption of
Decrease
itraconazole.
absorption of itraconazole.
Why?
Because itraconazole need acidic medium, sir.
Itraconazole need acidic medium, yes. So when azole antifungal administered, it needs acidic medium. So azole antifungal absorbed from acidic medium. So what? They are absorbed mostly in the stomach. When you give another drug that decreases the acidity, like PPI, antacids, or H2 blockers, they will decrease the acidity so that the absorption of the antifungals or azole antifungals will be decreased. Therefore, this is the right answer here. What is the rancidity? It's one of the questions that repeated many times previously. Rancidity, actually, it is the oxidation of the double bond of the fatty acid. Okay, when we have a fatty acid with long chain and having double bond, this double bond will be oxidized. Okay, so here it will give, this is the double bond, it will give OH. This is the oxidation of this double bond, or one OH. So this is the rancidity. This is called the rancidity of the fatty acid. The highest negative inotropic drug. As you see here, we have 4 drugs belongs to calcium channel blockers. For calcium channel blockers, which of them is highest inotropic effect? It is verapamil. Okay, it is verapamil. Let us take a look about the calcium channel blockers. We can classify them into 2 groups. Dihydropyridines and non-dihydropyridines. Dihydropyridines like dipene family. Amlodipine, nifedipine, nicardipine, philodipine, all of them are dihydropyridines. This is regarding to the structure of them, which contain this ring. This is the ring of dihydropyridine ring. Okay, and having the substitution here and here. While non-dihydropyridine, we have 2 drugs, verapamil and diltiazem. The difference between both in the activity, all of them having calcium channel blocking activity, all of them will affecting the vascular smooth muscle, but with different degrees. Some of them will affect the heart more than the vessels, and some of them will not affect the heart at all. So let us draw this. This is the heart, and this is the blood vessels. We will put verapamil under the heart. Then diltiazem. Then nifedipine. Then amlodipine. Okay? So you will find amlodipine directly under the blood vessels. So it is only affecting blood vessels, not affecting the heart. Therefore, it is safe with patient having congestive heart failure because it will not affect the heart. While verapamil mostly affect the heart, not the blood vessels. They will affect the blood vessels, so can be used in hypertension, but not like or with no effect like amlodipine in hypertension. Diltiazem mostly affect the heart with a little effect on blood vessels. Nifedipine mostly affect the blood vessels with a little effect on the heart. Amlodipine will affect the heart. So when we study the uses of the dihydropyridines, you will find the following. For hypertension, generally, all calcium channel blockers used in hypertension. But for sure, amlodipine is better than verapamil in hypertension, than diltiazem in hypertension. Okay? In patient having angina, which is the better? Verapamil and diltiazem. And also you can use nifedipine with a little effect. So those can be used in angina, while amlodipine cannot. You cannot use amlodipine for patient having angina to treat this angina. Why? Because it have no effect on the heart. For arrhythmia, which is the most
verapamil.
effective? Yes, verapamil, diltiazem, with a little effect of nifedipine, with no effect in amlodipine. Amlodipine, we cannot use it in arrhythmia. For congestive heart failure, I mean here not to treat, but is it contraindicated or not? So take care here. Calcium channel blockers are not used in treatment of congestive heart failure because of the negative inotropic effect. So it is contraindicated. Okay, negative inotropic effect making calcium channel blockers contraindicated in congestive heart failure. But some of them, we can use them. We can use them in another condition plus the congestive heart failure. Suppose we have a patient having heart failure plus hypertension. So which of those is the drug used in hypertension? Verapamil, diltiazem,
Is amlodipine should be.
yes, amlodipine. So regarding to the calcium channel blockers, amlodipine here can be used. Nifedipine can be used, while verapamil and diltiazem should not be used at all. Okay, so this is an important point regarding to the calcium channel blockers. It is important for some questions in the exam giving you a case of a patient having 2 or 3 conditions. So you can judge which drug is the best for this patient according to the information that you have about each group of the drug. Let us see the next question. When a drug has a first pass effect in the liver, that means what? It is, or it has long duration of action, or it has high systemic effect, or less systemic effect, or has rapid onset of action. To understand this, the first pass effect, when the drug administered orally, it will go firstly to the portal circulation, then the liver will affect a part of it, will metabolize a part of it. Okay, therefore, its activity will be decreased. The remaining part will go back to the GIT for absorption. Therefore, you will find that its activity or systemic activity or effect will be decreased. The next one, which is most true regarding linear pharmacokinetics? Again, I will explain this because many persons have a confusion about this one, the linear pharmacokinetics and elimination reactions. Okay, let us differentiate between first order elimination and first order kinetics. Okay, first order elimination and first order kinetics. In first order kinetics, we called it linear pharmacokinetics. Okay, why? First order elimination is non-linear. What is the main difference? Here we plot a curve of concentration versus time for first order elimination. We study the rate of elimination in response to time, in response to concentration of the drug. Okay, When you administer the drug, it will go to the absorption, then distribution, then metabolism, and start to be eliminated. The highest concentration of the drug after absorption. Okay. At the highest concentration, the rate of elimination is very fast. Then the rate will be decreased gradually with this curve. Okay. When the concentration decreased, the elimination rate will decrease. This is the first order elimination reaction. While in first order kinetics, we plot a curve between the concentration versus dose, not time. So we'll see the response of different doses on the concentration of the drug. The dose will affected by the pharmacokinetic parameters, will affected by absorption, by distribution, by metabolism, and by elimination. Okay. So the question here, as we increase the dose, the concentration will increase by a linear relationship or with the same rate or not. This is the first order kinetics. When you increase the dose, you will find that the concentration will increase in this shape, in this curve. Okay? Here we have the first order kinetics. So the pharmacokinetics parameters does not affected by the dose. It is dose independent. The right answer here is T half is dose independent. Not only the T half, all pharmacokinetic parameters like volume of distribution is independent, dose independent. Clearance is dose independent. All other pharmacokinetic parameters are dose independent, not affected by the dose. So you'll find that drugs follow first order kinetics having a stable or a constant T half, while drugs having or follow zero order kinetics, the T half is dose dependent. According to the dose, we will have the T half, and we cannot define a constant or a specific T half for them. Like a drug like heparin, we cannot know what is the T half of it. Drug like phenytoin, we cannot know the T half of it. According to the dose, we can study the T half. Are there any question about this point? Especially, it is important to understand. The next question. All are true about GTN except. What is the GTN? It is glycerol, trinitrate. This is the abbreviation of the GTN. Okay, so it is one of the nitrates. So we are looking for the wrong statement. All are true except. Cause vasodilation, for sure, it is one of the vasodilators. Used in treatment of hemorrhoids. Yes. Sometimes the use of GTN in hemorrhoids as an ointment will decrease the pain. It will decrease the pain. So this is a right statement also. Used for chest pain of angina, for sure. Available as an enteric-coated tablet and ointment. This enteric-coated tablet not applicable. Why? Because of the first pass metabolism. 90% of the GTN will be subjected to the first pass metabolism, so that the remaining 10% will not give the needed effect for GTN or for nitrates. We cannot administer it as an oral. It is administered as sublingual or transdermal patch or intravenous preparation.
Can I ask you one question, sir?
Yes, please.
Nitro GTN, that like glycerine trinitrate, is available as an ointment, right? For the treatment of hemorrhoid, but not available as enteric coated.
Not available as an enteric coated, yes.
And okay, yeah,
The
it's ointment,
available
okay.
as an ointment, but it's not a common. It's not a common one because it
Okay,
have
thank you.
some specification or restrictions, but it is present already or can be prepared. Which laxative cause dependence? Psyllium, mannitol, isacodyl, or glucosate sodium. The dependence from laxatives happened with the which type? Isacodyl or senna. We call them under which type of laxatives?
Stimulant.
Yes, stimulant laxatives. Stimulant
Sorry,
laxatives that
sorry,
stimulate
Doc.
that.
Sorry, Doc. I wanted to ask, if you're saying GTN is a vasodilator, right? Then how come it relieves pain for hemorrhoids? Because my thinking is, now that we are dilating the vessels down there, probably are now restricting the whole thingy. And also,
Another effect of nitroglycerin is relieving pain. Okay? It's not related to the vasodilator effect of GTN or nitrates, but they found that it have another effect which relieving the pain of the hemorrhoids. So also, if you think about the angina, nitrates or GTN, we use it in angina. Angina have a problem with the pain, not only for the vasoconstriction or blockage of the vessels. The nitrates in angina, they are vasodilators and decreasing the pain of the angina. Therefore, the patient having stable angina, after 4 minutes of administration, they will feel less pain.
thank you so much.
Okay. Again, for question number 12, the bisacodyl is one of the stimulant laxatives that stimulate the peristaltic movement. Therefore, it may lead to dependence. Okay. While psyllium is one of the bulk-forming laxatives. It's like fibers. Mannitol is one of the osmotic fibers, of the osmotic laxative, while glucosate sodium is emollient. Also, glucosate can be used in another uses. It is surfactant, so can be used in pharmaceuticals or pharmaceutical preparation as a surfactant. Also for ear wax, can be used to solve the wax of the ear. This is the list of different laxatives according to their types and the mechanism of action. Isacodyl, the stimulant laxative with senna. Castor oil is stimulant laxative also. And oil.
மெசேஜ் பண்ணீங்க நான் பார்க்கல காலையில நான் இல்ல சைலண்ட்ல போட்டேன் பிக்கப் பண்ணிட்டாங்கல்ல
Please, your voice is not clear. If you have a question, try to ask it again. If you don't, please. For avoid interruption, close your mic. If you have a question, open your mic and ask. Okay. Magnesium sulfate. Magnesium sulfate is another laxative, as an osmotic laxative. It will draw water into the colon and increase the stool volume. Magnesium hydroxide, also like the magnesium sulfate. Lactulose is also an osmotic laxative, like mannitol. Those are some types of laxatives. All are used in treatment of cystic fibrosis, except one of the genetic disorders that affecting the lung, the pancreas, the liver, leads to blockage of mucus in the bronchi, so leading to decrease the trachea lumen. This is the normal trachea, and here we have cystic fibrosis, so the narrowing of the trachea leading to decrease in the breathing and difficulty in breathing. Here the mucus contain a DNA, increased its viscosity, making difficulty in breathing. So all of them will be used in cystic fibrosis. We can use antibiotics, we can use mucolytics, we can use a drug like Dornase alpha. But regarding to those choices, antifungals have no role in cystic fibrosis. Okay? Antibiotics and bronchodilators can be used, and acetylcysteine as mucolytics can be used. Dornase alpha will decrease the DNA that leads to increasing viscosity of the mucus, also can be used, while antifungals cannot be used. Within the pharmaceutical industry, the department which ensure that the facilities and system adopted are adequate is it quality insurance or quality assurance or quality control department? Quality control department regarding to the final product, studying the final product and see if it matching the specification or not, assess the final. While quality assurance will assess the facilities and system. Okay, so the right answer here is quality assurance department. Let us see this calculation problem. You have 20 milliliter ampoule with a concentration of 0.75%. And you need to prepare 250 milliliter of solution with a concentration of 0.125%. What is the volume of the liquid needed to be diluted? Okay, think about each word in the statement or in the question. It is a dilution. It is a direct dilution problem. What do we have? We have concentration before dilution is 0.75%. We have the 250. What is the 250? It is a volume after dilution. It is 250 ml. We have the concentration after dilution to be diluted to a concentration of 0.125%. And he asked about the volume of the liquid needed from this one or from this ampoule. So we need to know the volume before. Directly here we have the formula of dilution, concentration multiplied by volume before equal concentration multiplied by volume after. Okay. So volume before equal the concentration and volume after 0.125 multiplied by the 250, okay, over 0.75. I didn't mention something regarding to this. Before using this formula, you should check the units. You should check the units. Are they compatible or not? In both sides, the units should be similar. So here percentage and percentage. Here milliliter and milliliter. So that we can use the formula directly. The answer will be 42 ml. Okay. Another question, they may ask about how many ampoules can be used to do this dilution. The choices will be 1, 2, 3, 4. What is your response in this case?
Answer will be
2.
2. 3.
Is that
3.
3?
3.
2.
42 divided.
Yes, here the ampoule is 20 milliliter. And we need a volume of 42 milliliter. So how many ampoule? 2 or 3?
3.
What is
3.
3? 3 is the right. Why? If you choose 2, even we have extra 2 milliliters. If we choose 2, you will not get the right concentration. You will get concentration less than the needed one, or different than the needed one. Okay, so here we use complete or full 2 ampoules and 2 milliliters of the third one. Therefore, you will open 3 ampoules. The right choice here will be 3. Okay. The question for isomers, optical isomers and stereoisomerism, the enantiomers, stereomers, and mesocompounds. So let us understand it. We have 4 isomers of 2-chloro, 3-nitro-butane. Okay. The relation between isomer A and isomer C, this one and this one. What is the relation? Is it mesocompound, enantiomers, diastereomers, or chain isomer? To know them, let us put them beside each other and study the characters that present. Here the isomer A and here the isomer C. Okay. For isomer A, we have H here, Cl here, NO2 here, and H here. For isomer C, we have H here, and Cl here, and NO2 here. Firstly, how many chiral carbon present?
Is 2.
2 chiral centers. Okay. Are they mirror image to each other or not?
No.
Not mirror image. Are they superimposable or not? Can you put
Not.
the right one or the isomer C over the isomer A and give you a typical compound or not? Not. So they are not superimposed. Okay, they are not superimposed. Are they optically active or not? To know this, to know is it optically active or not, how can we know? Let us put a rule regarding to this point. If number of chiral centers less is odd number, or 1, 3, 5, 7, and so on, odd number, directly the isomer is optically active. While if the chiral centers are even number, 2, 4, 6, 8, and so on, you should check the compound itself. Does upper part is mirror image to the lower part or not. If it is mirror image to the lower part, so it will be meso compound. So if you divide the compound, let us put a compound like this. CH3, CH3, and here we have Cl, and here we have Cl, H. Okay. If you bend the compound over itself, what will happen? You will find that the upper part is mirror image to the lower part. Directly, this one is meso compound, not optically active. While a compound like what we have in this example, if you bend the upper one over the lower one, you will not find any mirror image because here we have Cl and here we have NO2. So it is not meso compound and they are optically active. Okay, so the optical activity is present. Optically active. Those four characters, chiral centers, not mirror image, not superimposed, optically active. For what? For enantiomers or diastereomers? It is for
Diastereomers.
Diastereomers. So here the answer will be diastereomers. For enantiomers, you should find that they are mirror image. So the isomer A and B, they are enantiomers. The isomer C and D, they are enantiomers. Okay? While A and C, they are diastereomers. B and C also, they are diastereomers. Okay? Also B and D. Let us see the next one. A type of radiation used in sterilization. Which type? Alpha, beta, gamma, or ultraviolet is gamma. Gamma radiation is the most popular form of radiation sterilization. It is used when materials are sensitive to the high temperature of the autoclaving, okay, but compatible with ionizing radiation. The material should be compatible with the radiation. It's one of the repeated questions many times previously. Not a method of contamination. Also this one repeated many times. Is it inclusion, exclusion, precipitation, or occlusion? Here we are not talking about bacterial or fungal or viral contamination. It is impurities of the powders. So the mechanism of contamination here is not exclusion. Exclusion is not one of the contamination mechanisms. We have four mechanisms: inclusion, precipitation, occlusion, and surface adsorption. Okay, the fourth one is adsorption. How many optical isomers are possible for 2-amino-propanoic acid? This structure having how many stereoisomers or optical isomers? To know that, firstly, we should define how many chiral centers present. You'll find that there is only one chiral center here. So we use the formula of 2 to the power n. N is the number of chiral centers. So 2 to the power 1 equal 2. We have 2 stereoisomers for this compound. Another calculation problem, let us solve it. A patient brings you a prescription of 16 milliequivalents of potassium chloride. Okay? Your pharmacy has 600 milligrams of potassium chloride controlled release tablet. You don't have powder of potassium chloride, but you have this tablet or controlled release tablet, each of them having 600 milligrams of potassium chloride. The question here, how many tablets are needed? To know that, we should know the milligrams needed of potassium chloride. How many milligrams? How can we know that? From the formula of milliequivalence. Milliequivalence equal weight over molecular weight over the small n. What is the small n? It is the valency of positive or negative ion multiplied by its count of positive or count of negative ion. Which positive ion present? It is potassium. Its valency is 1. How many potassium present? Is 1. So the small n here is equal 1. Number of milliequivalents here is 16. So the weight in milligrams equal 16 multiplied by the molecular weight that given, 74.5. Okay, you will get the weight in milligrams. The total weight. How many tablets? If we have 1 tablet by 600 milligrams, 1 tablet equal 600 milligrams. We need the total milligrams here. So how many tablets? By crisscross, you will get it. It will be 2 tablets. Yes, the answer is 2. The highest capacity pulmonary volume. Is it tibial volume, vital capacity, forced expiratory volume, or residual volume? Okay. The highest capacity of pulmonary volume among the option provided is the vital capacity. It is the vital capacity. The vital capacity is the maximum amount of air that can be exhaled after maximum inhalation. It represents the total volume of air that a person can move in and out of their lungs during maximal breathing effort. Vital capacity is measured by taking a deep breath, expiration, followed by forcefully exhaling as much air as possible in exhalation or expiration. On the other hand, you'll find that the tidal volume refers the normal volume of air inhaled and exhaled during breathing. Forced expiratory volume, or FEV1, is a measurement of amount of air forcefully exhaled during specific time, during the first second. Okay? So it depends on FEV1 in measuring the asthma, the category of asthma. The residual volume refers to the volume of air that remains in the lung after maximum expiration. Okay? It is the air that cannot be forcibly exhaled out of the lung, and it is necessary to keep in the lung to prevent lung collapse. Let us see the next one. Leukocytosis. It refers to what? Leukocytosis refers to an increase of white blood cells. It is a condition characterized by an elevated number of white blood cells in the bloodstream. Also, it can occur in response to various factors such as infection, inflammation, tissue damage, certain medication, or as a result of certain disease. Okay. Also, it is an indicator of immune response or an underlying health issue. While decrease in RBCs, what we called it, is anemia. And according to the reason, we classify the anemia. The decrease in platelets called thrombocytopenia, while increase in RBCs We call it polycythemia. Which of the following is not metabolized by glucuronidation? Glucuronidation is one of the types of metabolism, phase 2 metabolism. It is a common phase 2 metabolic reaction. Okay, the most common is 2 metabolic reaction. It is happened by conjugation of glucuronic acid to the functional group of the drug. Either it is carboxylic group, hydroxyl group, sulfate, or amino group. Okay, all those containing the functional group that bind to the glucuronic acid, while alkene does not. Alkene means we have a hydrocarbon having double bond C, double bond C. There is no functional group that bind to the glucuronic acid for alkenes. What is the right site of action of the following drugs? Each drug having its specific site of action. Here we are talking about diuretics, as you see. Furosemide. At which part of the nephron furosemide will act?
Loop.
Loop of Henle, especially ascending part of loop. Spironolactone. At which part of the nephron it will act?
Collecting duct.
Collecting duct. Mannitol.
Everywhere.
All parts.
All parts, not only in the glomerulus. Okay. Thiazide.
Correct. Distal.
This is correct, in the distal tubule. Acetazolamide.
Proximal.
Which part?
Proximal tube.
Proximal.
Doctor, since we're talking
Yes.
about the diuretics, but please,
Yes.
can you remind us about the low ceiling and high ceiling? I remember that the
Low
low
ceiling
ceiling
and-
is the thiazide, but the high ceiling one, I forget it, sorry.
Loop diuretic.
Low ceiling means, yes. Low ceiling means what? Low ceiling means the maximum effect obtained with a small dose. It is the meaning of low ceiling. Here we have an example like thiazide with low ceiling. The high ceiling is the loop. Okay, means that the maximum effect can be obtained with a higher dose, or when you increase the dose gradually, still you have an effect till the maximum effect with a high dose. Okay, while low ceiling, the maximum effect can obtained by low dose. Okay, for
Okay,
example,
thank you.
hydrochlorothiazide, we cannot get extra effect if you increase the dose over 25 milligrams. Another example of non-ceiling drug. This is the drug
Opioid.
that have no upper limit. Yes, opioids are an example of non-ceiling. This means that when you increase the dose, you will get extra effect without any upper limit. But for sure, you will get a side effect, more side effects. And you can get the
Thank you.
toxicity from it.
Doctor, is a similar like zero order kinetics and first
No,
order
no
kinetics
relation.
is not
No relation at
relationship,
all.
yes?
No relationship
Are
at
the
all.
parameters well affected by the dose here, by the concentration, or no,
No,
dependent or
no,
independent?
it is just a characteristic of the drug, not related to the pharmacokinetic
It's
parameters
another
at
thing.
all. Just a character of the drug. This drug, when you
Okay.
increase the dose, you will get extra effect. But another drug, when you increase the dose, you will get the maximum effect and there is no extra effect. There is no direct.
It's just those, not relationship with time or everything, yeah?
The relationship here between the concentration and the effects, yeah?
Yes, the dose and efficacy.
Between the dose and the effects, yeah.
Dose and efficacy.
So more like potence. We're dealing with potence, isn't it? High ceiling, is it?
High ceiling. We cannot compare between a potency between furosemide and thiazide. Those are different mechanism of action. So you cannot do that. You cannot say that the potency of thiazide is more than the potency of loop. It's not applicable to compare here because we are talking about different drugs. When you compare between potency, if there is two drugs having same therapeutic effect, and one of them having a lower dose that gives the same effect of the other, which needs higher dose. Like when you compare between candesartan and irbesartan. Okay? Or when you compare between ibuprofen and naproxen, both of them having the same effect. Candesartan and irbesartan, both of them are ARBs. Okay, so finally, the same efficacy will be obtained. The efficacy that can be obtained from candesartan with a low dose is similar to the efficacy that obtained from irbesartan with a higher dose. So we can say that candesartan is more potent. Is it clear?
Yes, thank you.
Thank you, doctor.
The last question today. Here, liquid paraffin. Liquid paraffin is liquid saturated hydrocarbon or liquid unsaturated hydrocarbon or water soluble ointment base, or is it causing constipation when administered orally? For sure, liquid paraffin is on the legs there, not causing constipation. It is lipid soluble, not water soluble. Is it saturated or unsaturated? It is saturated.
Saturated.
Without any double bond. So the right answer here is liquid saturated hydrocarbon. This was the last question today. Okay, let's see some questions from you. One question about question number 7. Let us discuss it again. Let's go back to the question number 7. Question number 7. Regarding to the rancidity. Rancidity is a character of the fatty acids which having double bonds. This double bond will be oxidized, and the oxidation of it called rancidity, and the result will call rancid oil or rancid fat. Okay. Any other question? So this means that everything is okay today. Okay, that's good.
Thank you, doctor. Thank you so much.
Thank you. Still, you have the opportunity to attend the full revision. As you know, from those lectures plus another 4 complete lectures regarding to paper 1, paper 2, and mixed recalls, and the most recent recalls will, which we will conduct it soon. The most recent recalls contain questions from the recent or the last recent exam. Okay, so you can join us from this link to join the full revision. And if you want to ask us anything at any time, please contact that. Still, we have another 3 divisions. So I hope you follow us in those revisions. Thank you so much for your attendance today. I hope it was useful for all of you, and see you in the coming revision lecture. Goodbye.
Thank you, Doctor. Bye.
Thank you. Bye.
Thank you.